Okay, my name's Hugh Reid. I'm an emergency physician in Newcastle, which is just north of Sydney in Australia. I think emergency physicians are probably the clinicians who deal the most with case presentations. I would get, in a 10-hour shift, I would routinely get, I don't know, 30 or 40 cases presented to me, and perhaps even more, where I've got to make decisions on them. So I'm good at finding out what information I need to know, and in turn, being able to put that into a hierarchy and present that information if I'm ringing another consultant, for example. Um, so many of the junior doctors and the medical students who come and present cases to me have never been taught how to do complex patients. Um, so that's what this is about. It's about the sophisticated case presentation um, of the complex patient. Um, the first thing that junior doctors do when they present to me is they want to go straight into the history of the present illness. So I'll tell you why you can't do that. When you start a presentation, why do you start with age and sex? Everybody knows that you do, but does anybody actually know the reason why? I've spoken to maybe one or two people who have worked it out, but I don't know that anybody is actually, I've spoken to anybody who's actually told me and has been told why you collect this information. You want to know age and sex. Well, so imagine that I started presenting a case of oh, I just seen this patient and they've got abdominal pain. It goes from here down to there, and they were sweaty, and they were, if you don't know if they're male or female, it makes a big difference. If you don't know how old they are, it makes a big difference. A 4-year-old with abdominal pain is different from an 80-year-old with abdominal pain. You say age and sex because it changes the pathologies that you're expecting. So, by the same token, when you're presenting a patient, you can't present the history of the present illness without also presenting the past history. So what you do in summary is you got a 15-year-old who's got 15-year-old girl who's got right-sided iliac fossa pain. I think she's got appendicitis. That's a really good summary. You've seen the patient, I haven't. You've got some idea about whether you think they've got appendicitis or not. You've always got the top sort of few diagnostic um, likelihoods in your mind. So saying what you think's going on is fine. You may be right, you may be wrong. That doesn't bother me, because if you're not right, well, then we can go through how I would pick what criteria I would use to say it's appendicitis versus mesenteric adenitis or something else. But it's useful to say what you think's going on. If you don't know what's going on, then just use the algorithm. 15-year-old girl with right iliac fossa pain, or with breathlessness, or something like that. The past history is incredibly important, because if you're seeing a 40-year-old with abdominal pain and you don't tell me their past history before you tell me about their abdominal pain, if you start telling me at the end that they're a severe vasculopath and that they've had bilateral above knee amputations and they've had aortic reimplantation therapy and carotid artery bypasses and things like that, I'm not going to even be thinking about vascular disease as a cause of abdominal pain in a 40-year-old. But if you say, oh, I've got a 40-year-old vasculopath with severe Berger's disease who's had all these amputations and bypasses, and now they've got abdominal pain, and I'm going to be going, oh, okay, maybe we need to do an arterial CT or something in this patient to figure out what's going on. So you have to tell the past history before you tell the history of the present illness. Age appropriate. Complications. I'll leave you to read through some of this, because there's some of it which I'll speak to directly, and there's some of it that's not. Yeah, the art of the sale. The whole point of doing a case presentation, I remember being a bit confused about what this was about when I was a medical student, and I sort of got the hang of it, but it didn't click until a number of years later what the whole thing was about. When you're doing a case presentation, you want to get the person at the other end of the phone, or the person who you're talking to, saying yes, because you want them to accept the fact that you want to be doing a competent case presentation. And if you're speaking to a physician, or you want to admit somebody to the intensive care unit, or you want to talk to the surgeon and say this person needs an urgent operation, you need to be able to put all of your ducks in a row and point out in logical order why you think the things that you do and why it leads to the logical conclusion. So the reason you're doing all of this stuff, and if you watch my other videos which are after this about the past history, how to get a cohesive past history and how to make it coherent and elegant. If you can present to the intensive care physician, and I've got a 62-year-old lady who's got mild ischemic heart disease, who's got breathlessness, which I think is actually due to a viral pneumonia. I don't think it's heart failure. I don't think it's coronary artery disease, but they're actually severe enough that they're approaching ventilation. They're on high flow. They've got high oxygen requirements. They're not quite CO2 retaining yet. You can see how the logic of those things makes sense, and the intensivist is going to look at it and say, okay, I've got somebody who's got maybe a bit of a bad heart, who's breathless. It's clear in what I'm saying that I'm differentiating between the different causes of those breathlessness, the different causes of the breathlessness, and you want to get your ideas across in a simple sort of manner so that people can understand what you're saying. If you start going through a whole list of diagnoses and things, their eyes are gonna glaze over, because then they've got to process everything. You want to try and summarize it all to make it simple. The consultant level. Yeah, I mean, when you're a junior doctor, when you get through medical school, you'd be expected to do a simple case presentation. By the time you get to registrar level, that you want to have a degree of sophistication to your case presentation. When you're a consultant, you work at a slightly different level again, because you don't have to justify to the consultant why you think particular things. They'll accept the fact that you've got clinical experience and that you know probably what's going on. Often what I'll do is use that different silos. I've got a patient who's got say, well, that last example of the talking to the intensivist. I've got a patient who's got breathlessness. I know that she's a bit of a vasculopath, but I haven't got any convincing evidence that this is vascular related, because she's not been complaining of chest pain. She's not got swollen ankles. She hasn't got signs of heart failure. She hasn't got radiological signs of heart failure. I think it's infective because they've had a viral upper respiratory tract infection which led on to this. COVID's just messed this whole thing up, hasn't it? And because they've got soft wheezes in their chest or something like that, and a patient who's got no history of asthma and no history of smoking. So you're siloing, and you're going on a diagnostic, much more a diagnostic sort of reasoning for why you think a particular pathology is going on. Okay. Medications and severity scoring. Medication lists. I don't know how often I've seen medication lists coming in which are alphabetical. It drives me crazy. It's often alphabetical using their brand names, not even using the generic names. You have to put the medications together. You have to put all the cardiovascular medications together. You put the respiratory medications together. Put all the pain and mobility medications together, because when you've got them like that, you can severity score things. And when you can severity score things, you can start looking at what's going on with the patient. Are their chronic diseases actually influencing their current presentation? Somebody who's got bad heart failure and mild COPD who turns up breathless, the money's going to be on heart failures, of course. Um, so when you are able to severity score diseases, I came into the emergency department one day and found a patient who was on BiPAP, but there were no intensive care beds, and we were miles away from the next intensive care unit. So the question, what do we do with this patient? The first thing I did was call the local pharmacy and get them to fax over a list of their medications. And what we saw was that they're on cardiac, 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 cardiac. So we started a GTN infusion, a nitrate infusion, and we wound that up until the blood pressure was down to 110, 115 or something like that. And we were able to wean the BiPAP off and just get them onto some low flow mask oxygen. And the patient went to coronary care unit where there were beds. So knowing what's going on, knowing how severe somebody's respiratory disease is, I'll do another a video on scoring systems in chronic disease, but working out how all of these things interact in a patient who's got multiple diseases is actually one of the hardest parts of modern medicine. And if we make it hard for ourselves, then we don't do ourselves any favors. Okay, I'll see you in the next video.